Oh, I think Marina just started the broadcast.
No,
Hello.
that's not good. Hello,
Can you hear
Marina.
me?
Marina, you should not start February 27, 2018, 4 p.m. Central European Time. And it's my great pleasure to welcome you to the second webinar organized by the European Reference Kidney Network, organized by Professor Franz Schaefer from Heidelberg. My name is Elena Levchenko. I'm a pediatric nephrologist from Leuven, Belgium, and I will be a moderator of this webinar. During the webinar, the slides will be projected on your screen, and you will be able to send us your questions using a special tab on your attendee panel. Please use the tab rather than sending questions by email. Questions can be sent anytime during the presentation and will be answered at the end of the webinar. 162 attendees have registered to this webinar. However, we have mentioned from our previous session that in some centers, several people were following using the same login. Therefore, I would like to ask you to fill in the real number of colleagues who will follow with you in the survey which you will receive after the webinar. Let me now introduce the speaker of today. It is Dr. Marina Vivarelli from Bambino Gesù Children's Hospital in Rome. Dr. Vivarelli is a pediatric nephrologist and a pediatric rheumatologist. She is a top expert in complement-mediated kidney disorders and in the immunology of nephrotic syndrome. Marina has published a lot in high-impact scientific journals, including the New England Journal of Medicine, Journal of American Society of Nephrology, Kidney International, and our favorite pediatric nephrology journal. She is a chair of the Working Group on Nephrotic Syndrome in the European Society for Pediatric Nephrology and is a co-chair of the Immune-Mediated Glomerulopathies Working Group of ERKC3. The topic of your talk today is C3 glomerulopathy. The webinar will be recorded and the slides will be published on the website of ERKC3. And now I would like to ask Marina to start with your talk. Marina, we are really eager to hear you, please.
Good afternoon. Thank you very much to Elena for this kind introduction. It is my great pleasure to speak with you this afternoon to introduce my topic, which is C3 glomerulopathy. This talk is intended to be of general interest to the pediatric nephrologist and also to the nephrologist. And it is a clinical talk. I will try to give you some clinical indications and some ideas of new therapeutic perspectives that may be useful in treating children and adults with C3 glomerulopathy. I will be happy to answer questions at the end of my talk. So to get started, sorry. There. Okay, sorry for that. This is the old classification of membranoproliferative glomerulonephritis as we knew it until about 10 or 12 years ago. And we subdivided these membranoproliferative glomerulonephritis into 3 types based on the location on electron microscopy of the deposits. If the deposits were subendothelial, we called it type 1. If the deposits were intramembranous, we called it type 2. And if the deposits were both subendothelial and subepithelial, sometimes with humps, we called it type 3. And what we knew was that type 2, also termed as dense deposit disease, was special and particular in that it had recognized some alternative pathway of complement dysregulations in its pathogenesis. However, in 2017, the group led by Aude Servet in France identified a new primary glomerulonephritis. This primary glomerulonephritis has isolated C3 deposits, and in these 19 patients, alternative pathway of complement alterations were found either with C3NF positivity or with mutations in genes that are known to regulate the alternative pathway of complement. However, these patients did not have dense deposit disease. They had deposits that were either mesangial or hepimembranous, and by immunofluorescence, they had a prevalence of C3. This new entity was called C3GN, or C3 glomerulonephritis. And this really created a new idea in which in kidney diseases, we talk about complement alternative pathway dysregulation leading to a spectrum of diseases. When the activation is local, we have atypical hemolytic uremic syndrome. When the activation is systemic, we have a group of glomerulopathies that can be either dense deposit disease or C3 glomerulonephritis that are collectively termed as C3 glomerulopathy. The distinction between C3 glomerulonephritis and DDD requires electron microscopy, as you can see here, and the deposits by electron microscopy really look very different. The other important thing to remember is that in C3 glomerulonephritis, you can have humps, which were previously considered to be typical of acute post-infectious glomerulonephritis. These important studies published by the Sanjeev Sethi and the group at the Mayo Clinic showed that if you look by proteomic profile in microdissected glomeruli, you find that both patients with DDD and patients with C3GN have very similar profiles in the components of complement that you find deposited in their glomeruli, indicating that these two diseases have a very similar pathogenesis driving the disease. If you look at the renal biopsy in C3 glomerulopathy, by light microscopy, you have a very heterogeneous aspect. You can have mesangial proliferation, you can have a membranoproliferative GN, or you can have diffuse endocapillary proliferation. The unifying feature is the intense deposition of C3 that is visible by immunofluorescence. And in a consensus conference that was then published in Kidney International in 2013, it was stated that this immunofluorescence must be at least twofold brighter than all other immunofluorescences to define C3 glomerulopathy. Another important concept is that the reason why the light microscopy is so heterogeneous is that probably there is a continuum between the different types of lesions that we can see by light microscopy, depending on the timing at which we perform the renal biopsy. So in 2012, a new classification of membranoproliferative and more in general of proliferative glomerulonephritis was proposed based on immunofluorescence and on electron microscopy. If you have positive IgGs or immunoglobulins in general and C3, you have a form that is Ig mediated that can be secondary to all these different causes that I am showing you here: monoclonal gammopathies in adults, autoimmune diseases, and infections at all ages. If you have predominance, clear predominance of C3, you're thought to have a proliferative glomerulonephritis that is complement mediated, that is termed as C3 glomerulopathy. And by electron microscopy, you then distinguish between DDD or C3GN. So we know that there are a whole variety of different factors that can lead to the abnormal C3 convertase activity and therefore to an abnormal upregulation and dysregulation of the alternative pathway that then leads to C3 glomerulopathies. This can be due either to the presence of antibodies such as C3 nephritic factor that keep the C3 convertase abnormally activated, or antibodies directed against complement regulators such as factor H, factor I, or factor B, or mutations in genes that regulate complement alternative pathway, allele variants, or mutations in complement factors. Since the dysregulation is in the fluid phase, we can have extrarenal features as well. And this is important to remember because we have to look for these features in our patients. One of the features which is easy to see is partial lipodystrophy. And another one which we have to instead look for is drusen, which is the deposition of lipids and proteins containing also complement in the macula of the retina. And these can lead to blind spots. For the nephrologist, the clinical presentation of C3G is very heterogeneous, and I will now give you a whole variety of clinical pictures that have to make you think of this diagnosis. One is post-infectious glomerulonephritis with low C3. We see that all the time. And however, if you have a low C3 that persists for more than 12 weeks, or if you have recurrent macrohematuria, you have to think that this can be a form of C3 glomerulopathy. In a retrospective study published again by the Mayo Clinic group in 2012 in Kidney International, they saw that looking back at about 100 of their patients that had had post-infectious GN, they found 11 in which there were mutations or antibodies leading to dysregulation of the alternative pathway of complement. So in reality, these patients did not have acute PIGN, but rather they had an atypical form, which is a form of C3 glomerulopathy. These patients tend to have humps, maybe a little bit fewer than what we typically expect to see in post-infectious. They tend to have a little bit of IgG by immunofluorescence, but less than what we expect to see in classical post-infectious. And they can have a very varied aspect by light microscopy. Frequently, they have quite acute presentation with lots of florid diffuse proliferation. Otherwise, you can have patients with C3 glomerulopathy presenting just like an IgA nephropathy, so with a macrohematuria that is triggered by an infection. And this was very nicely shown in a beautiful paper published by Daniel Gale in Lancet in 2010, where he showed a form of C3 glomerulopathy depending on mutations in complement factor H-related proteins. In patients of Cypriot origin, this was then described also in other families. And patients that have these mutations have an alternative pathway dysregulation, and clinically they present with a picture that is very similar to IgA nephropathy. Interestingly, more recently, also in IgA nephropathy, mutations and variants in genes regulating the alternative pathway of complement have been described. Another presentation, which frequently is the most serious and severe presentation of C3 glomerulopathy, is patients presenting with nephrotic syndrome. Another case is instead the mildest form of them all, which is the accidental finding of non-nephrotic proteinuria and microhematuria. The patient can do a routine urinalysis, for example, for sports activity or for any other medical reason, and accidentally in a patient that is clinically fine, these alterations of the urinalysis will be found, a renal biopsy will be performed, and surprise, surprise, a C3 glomerulopathy will be found. If we look at our cases described recently seen in our hospital, out of 32 patients, we saw that we had 13 presenting as acute GN, 11 presenting as nephrotic syndrome, and 8 presenting with the random urinalysis. And it is interesting to see that, at least in our experience, the patients that presented with acute GN all had a really good outcome. And quite a good outcome also in the patients presenting with random urinalysis, whereas definitely the ones with the most severe outcome tend to be the ones that present with nephrotic syndrome, confirming what has been seen also by others. A third atypical presentation of C3G that I wanted to briefly present to you because it can be quite interesting and difficult is this one. This is a child that we saw in May 2014 who arrived to us from another hospital because he had hemolytic uremic syndrome and he needed dialysis. He was negative for varotoxin and he had normal at MTS13. So we did a complement workup for mutations and we started therapy with eculizumab. He did much better with eculizumab, but when his urine output increased, we saw that he had proteinuria in the nephrotic range and that he had also persistently low circulating C3. Therefore, we performed a biopsy, and the biopsy, to our great surprise, showed a proliferative glomerulonephritis with intense C3 and not much IgG. Only by electron microscopy were signs of chronic TMA visible. So this child had a mixed picture, which is described of an atypical hemolytic uremic syndrome and a C3 glomerulopathy. And he responded, by the way, beautifully to eculizumab. So really, if we think about C3 glomerulopathies, we see that it's a spectrum of diseases within which we have on one side the atypical post-infectious forms that goes towards classic post-infectious but are different because this is a chronic disease, and forms, the ones that are secondary to mutations in complement factor H-related proteins, which can look very similar to IgA nephropathy. In these forms, traditionally, what is said is that there is always predominant, at least twofold C3 deposition. However, even in papers that were published quite a few years ago, it was described that there could be patients that had intense positivity also for immunoglobulin, but that were found to have mutations or other alterations in the alternative pathway of complement. For example, in this important paper that was published by Survey's group, again, in Kidney International in 2012, out of their cohort of about 100 patients, 18 patients that had intense immunofluorescence positive for IgG, IgM, C3, or IgG, IgM, IgA, and C3, but definitely not a predominance of C3, were all found to have positive C3 nephritic factor. Another important paper that was published by a registry of MPGNs by the group led by Professor Remuzzi in Bergamo showed a similar finding. When they looked at patients both with immunoglobulin MPGN and with C3G, they found that both the percentage of C3NAF positivity and the percentage of mutations, and both, were absolutely reproducible and similar in both groups, showing that there is a substantial percentage of patients with idiopathic immune complex MPGN, so obviously idiopathic, not secondary to autoimmune disease, that have complement alternative pathway dysregulation. I will show you also some biopsies that exemplify this. This was a girl that presented to our hospital at 12 with a nephritic syndrome. We performed a biopsy and she had a full house nephropathy. However, when we repeated the biopsy after immunosuppression, we found a clear picture of C3 glomerulopathy. She had positive C3NAF and MCP mutation, elevated C5b9, and persistently low C3, so features that are typical of a C3 glomerulopathy. Another patient instead was this child who presented at age of 7 with a nephrotic syndrome with some microhematuria. His first biopsy was typical C3 glomerulopathy. We then rebiopsied because he wasn't responding well to therapy about 8 months later. And despite intensive immunosuppression, he really looks like a full house immunofluorescence, despite having clear signs of DDD by electron microscopy. This child has positive C3NAF, no found mutations, normal C5b9, and persistently low C3. So really, I think that we need to say that in C3GN and immune complex MPGN, there is probably a lot of overlap, and that in this group of patients with so-called C3 glomerulopathies, C3 deposition is often predominant, but it is not always exclusive. And immune complex MPGN can be part of this spectrum of diseases. So how can we make sense of this heterogeneity? Definitely the clinical presentation of these patients is very heterogeneous. The light microscopy is also very heterogeneous. The immunofluorescence can be helpful with C3 predominance, but it's not always the case. There can be IG, and also C1q does not exclude a complement alternative pathway dysregulation. By electron microscopy, with intramembranous highly electron dense deposits, that is diagnostic, as it was 50 years ago, of dense deposit disease. The serology, circulating low C3 can be useful with normal C4, but it is not always present. So we do really need to do the genetic and serological full phenotyping in a specialized center in order to identify the mutations or the antibodies that lead to a dysregulation of the alternative pathway of complement. So this is a list of the things that it is useful in terms of circulating factors, autoantibodies, and genes to look at if you have a clinical suspicion of C3 glomerulopathy. Another interesting thing is that interesting studies have been published that show that there are some hints that one can get by dosing different complement factors in the circulation to understand whether the patient is more likely to have a C3GN or a DDD. And in general, these two papers seem to indicate that a C3 convertase dysregulation is more likely, so more upstream, is more likely in patients with DDD, and a C5 convertase dysregulation is more likely in C3GN. And this obviously has therapeutic implications as we move forward to having complement inhibitors that can act at different levels. Another interesting paper that was published last year in JASN, again by the group led by Professor Remuzzi in Bergamo, showed that if you look at 173 patients, both with immune complex and with C3G, and you use a cluster analysis, which is a statistical analysis completely unbiased, in which you look at a group of genetic, serologic, histologic, and clinical features, you can identify 4 groups that have common features and that may be presumed to have distinct underlying mechanisms and therefore different prognosis. The first 3 groups are groups that have low C3 and frequent mutations in alternative pathway genes or C3NAF positivity, so in whom there is a fluid phase alternative pathway dysregulation. In these 2 groups, there is elevated C5b9. In this one, there is normal C5b9. And this second group tends to be almost always DDD. The fourth group instead is a group based with late onset marked sclerosis and poor outcome. And these patients normally have normal C3, and infrequently we find mutations in the alternative pathway genes or in C3NAS, pointing to a solid phase or to a low-grade continuous fluid phase alternative pathway dysregulation. This also may have therapeutic implications as we move forward with different complement inhibitors. In terms of outcome, we know from the studies that have been published that these patients can have quite a dire prognosis. GFR last follow-up is frequently abnormal, and frequently these patients, up to 50% of cases, recur post-transplantation. If we look at risk factors, definitely sclerosis at onset, crescents and nephrotic syndrome are bad prognostic factors. And also the absence of mutations or C3NAS may be indicative of a poor prognosis. So how do we treat C3G? Well, first of all, it is important to remember that whatever the dysregulation of the alternative pathway of complement, due to the fact that C5a and C3a are important anaphylatoxins, in the kidney you're going to have a lot of inflammation. And conventional immunosuppression can do a lot to turn off that inflammation. This is an important paper published by a Spanish group in 2015 in Kidney, which shows a clear benefit of mycophenolate mofetil and also a benefit of cyclosporin and of conventional immunosuppression versus patients in the lower bar that did not do immunosuppression. So when the KDIGO guidelines were done last year, what we suggested was that all patients have optimal blood pressure control and diet and lipid control. In the presence of moderate disease with proteinuria that is above 500 milligrams in 24 hours and moderate inflammation on the renal biopsy, you can use prednisone and MMF. In the case of severe disease with the nephrotic range proteinuria or an increase in serum creatinine and severe inflammation on the biopsy, IV methylprednisolone and maybe anticellular immunosuppressants may be considered and may be limitedly useful. But we felt that at this point there was insufficient evidence to recommend eculizumab as a first-line agent. However, as you all very well know, anti-C5 blockade with eculizumab has been tried in these patients as well. And I will just briefly show you one patient that we published many years ago that was the first patient with dense deposit disease to be treated with eculizumab. And if you see look at this graph, he really did have a very convincing response in terms of proteinuria. When we interrupted here in white the drug, his proteinuria went back up, and it went back down when we resumed treatment. And we also saw a reduction in C3 deposition and in C5b9 deposition, and an improvement in the thickness of the glomerular capillary walls. However, not all patients have responded well. It may work better in patients that have elevated soluble C5b9, so a terminal complement pathway activation. It is a very expensive drug, and there is a significant risk of meningococcal infection. There are many other complement targeting therapies on the horizon that are going to be available or already available. So the important thing is to try to have an idea of at what level the dysregulation in your specific patient is. If you think that it's at the level of the C5 convertase, you can think of using eculizumab or the new oral CCX168 drug, which is being tested for this indication. If you think that your alteration is, again, in the fluid phase but upstream, it can be useful to block the C3 convertase. And in blue here, I have put two drugs that are being currently tested. If you instead have the impression that the activation is in the solid phase, it could be useful to block the C3 convertase at sites of local endothelial or glomerular activation. And this is a substance that could be useful in this sense. I would like to thank all of these people for helping me to prepare these slides, and thank you very much for your attention. I would also like to indicate that this is the next webinar. It will be given by Dr. Olivia Boyer on March 13, again at 4 p.m., and the title is going to be Genetic Forms of Podocytopathies in Adults. Thank you very much, and I will be happy to take questions.
Thank you very much, Marina, for this very comprehensive presentation. There are questions coming, so please send more questions to us, and in the meantime I will ask the question from Dr. Jacques Wetzels in Nijmegen. So the question is there sufficient data to support the use of complement C5b9 levels or other complement factors to predict response to any treatment?
I think that's a really good question. There is probably more evidence that is going to be published in the near future. Given the published evidence at the moment, the impression is that soluble C5b9 can be a useful predictor of response to therapy blocking the terminal complement pathway. So, for example, therapy with eculizumab, or potentially also with avacopan or CCX168. But I think there is experience of these agents potentially being useful also in patients that have normal soluble C5b9. So I would not necessarily rule them out in the presence of a normal soluble C5b9. And I really think that we need to have a clear understanding of the complement profiling of these patients as we move forward, and that any clinical trial that is designed in this phase needs to carefully assess all of this complement profiling before and during treatment to gain useful information about how to go forward in treating these patients.
Thank you very much. I'm just looking whether there are some other questions. So people who have questions, please send them. Yeah, there is a question from Dr. Ilse Roth. The question is, how often do extrarenal features occur?
Thank you for that really good question. So in my experience, the lipodystrophy is really exceptional, even though we have seen it. Whereas the drusen, if you look for it, I would say that about 30% more or less of patients will have it. My perspective is a perspective of a pediatric nephrologist, and since this is a progressive form of lesion, it is possible that it is even more frequent in older patients.
Very good. I have another question, but it is not complete. Yes, the question from Dr. Malakaziotti. She asked whether there is place on the use of plasma exchange therapies.
Excellent question. So there are some papers that have been published, especially by the group of Christoph Licht at Toronto, showing a benefit of plasmapheresis. The difficulty with that is that it needs to be extremely, extremely intensive, because you really need to completely substitute the complement and in order to be effective. And so it becomes quite difficult from a practical point of view, and the benefits need to be weighed with the potential risks of this intensive plasmapheresis as well. So currently, even when we did the KDIGO guidelines, all in all, we did not feel that we would recommend this clinical approach, but it has been used in some cases successfully.
Thank you very much. The questions continue to come. So the next question is from Dr. Miglinas from Vilnius, Lithuania. The question is about patients with C3 glomerulopathies, whether the living donation is recommended or not.
Whether what, sorry?
So whether in patients with C3 glomerulopathy, when they have to be transplanted, whether you would disrecommend living donation.
Oh, okay. I think that's still slightly controversial. All in all, I think that you know, if the living donor were entirely healthy, I wouldn't see a contraindication to a living donation. I think it would be a possible therapeutic approach, as it is done also for patients with atypical hemolytic uremic syndrome, in the cases in which you know, you have screened accurately the potential donor and he is negative for known genetic mutations.
Okay, very nice. Another question is, just have seen it, about the duration of eculizumab use in this patient. So when you start with eculizumab, how long would you continue?
There's really no answer to that. There really isn't enough evidence. It really depends also on the general condition of your patient and on the degree of renal reserve, whether it's a native kidney or whether it's a transplanted kidney. I think in general you would expect to see a response within 2 to 3 months, definitely within 6 months. And if you did have a response, it would probably be reasonable, as we did, for example, with our patient, to, after a few months, do a window and see what happens. And then if during the window of interruption, which needs to be at least 2 or 3 months, you see that proteinuria reappears or that the serum creatinine seems to increase, then you definitely have a proof that that patient needs to be constantly treated. Whereas if you remain stable, then you can probably wait and see, knowing that you have this as a therapeutic option in the future if he responded initially, which I repeat, not all patients do.
Okay, thank you again. Another question is again regarding the treatment. It is about the use of mycophenolate, whether you use it with or without steroids.
We use it with steroids. So even there, it's difficult to give accurate guidelines. These diseases are rare and none of us has a vast experience. But generally, especially in the pediatric population, we see pretty intense proliferation. And so we treat that with a combination of a glucocorticoid, prednisone, orally, or IV methylprednisolone associated with mycophenolate mofetil. And then we try to taper down the prednisone quite rapidly, but to leave the patient on mycophenolate mofetil. And we see that honestly, a substantial percentage of patients respond to this form of therapeutic approach, which is clearly not specific for the mechanism that is driving the disease. But despite this, it does appear to work.
Okay, thank you again. So I have another question, and it's again regarding the treatment. And since like treatment, yeah, because it's so controversial, is something maybe should be discussed in more detail, and maybe some more clear recommendations can be published. So this question is from Dr. Louisa Murer, and she asks, I just will read the question. In some cases of immune complex MPGN, IF positive endocapillary C3 and IgG with normal serum levels of C3 with nephrotic syndrome and macrohematuria and hypertension. The useful therapy will be probably steroids and MMF. And she asks whether the same therapy should be used in children under 1 year of age.
So the question is, if you have a clinical picture compatible with MPGN and you have a child that is below the age of 1, whether I would support the use of steroids and mycophenolate. Is that the question?
Yes, I think this is a question of whether the therapy should be similar to the older patients with similar histological and presentation.
So, I mean, in theory, yes, I would try. The only patient that we have had that was very, very young, who had a disease onset at 9 months, actually did not respond to conventional immunosuppression and had a genetic form of C3 glomerulopathy and actually did not respond to eculizumab either. So these are the really, really difficult patients. But I would try, because I do think that there is still a rationale for attempting this type of therapy, conventional immunosuppression in these patients, given the fact that a substantial percentage of them do respond.
Thank you again. So we have another question from Professor Wetzels from the Netherlands. Is mycophenolate mofetil more effective in patients with C3GN due to C3NF compared to patients with C3GN due to genetic mutations?
That's a really tough question. I don't know. And to the best of my knowledge, even in the published cases, they did not find a difference based on the cause leading to alternative pathway dysregulation. I mean, in theory, one could imagine that if it's an autoantibody mediated disease, it would work better than not if it's a genetic disease. But again, keeping in mind that C3A and C5A are anaphylatoxins with a lot of neutrophil recruitment, and that MMF and prednisone help a lot in that as well. You could also argue that they could be beneficial in the genetic forms. I don't believe that there is data indicating whether it is more beneficial in one form than the other. And in our clinical experience, I have not seen a difference. But I think that's a great question that would be really useful to put together a vast cohort of patients to try to answer that question.
Well, another question again about the treatment. In patients with multiple relapses of dense deposit disease, how long would you continue the treatment when the patient is in remission with mycophenolate? So the question is, when you have a frequent relapser, a DDD patient, and he's in remission under mycophenolate, how long would you continue it?
I mean, especially if the patient has had multiple relapses and presumably does not have a perfect, entirely conserved renal reserve, I would be quite unhappy about taking away a drug that has, if it has, proved itself effective and the patient has relapsed when it has been removed. So I would tend to keep her on mycophenolate, for a long time. Her or him on mycophenolate for a long time. I think that the potential immunosuppressive risk is far, far smaller than the risk of a relapse on his or her renal survival.
Okay, yeah, it's clear, or more or less clear. So I have another question from Dr. Nicole van de Kaap from Nijmegen. She asks about the titers of C3-NAP during the acute phase and in remission. Do you have this information? So how high is titers in this patient? And what they during the relapse and during the remission?
We have not used it as a marker of disease activity, so to see whether it is higher during active disease and it goes down during remission. It is published in some cases that this has been the case. C3-NAF is dosed in very many different ways around the world, and there are many different types of C3-NAF and very many different ways of measuring it. So this is highly dependent on how the test is performed, and in different settings you can get different results. So yes, in some settings it has been shown to be useful and to correlate with disease activity. In our experience, we use it more than anything to tell us that the patient has a disease that is driven by a dysregulation of the alternative pathway of complement and therefore falls within that group of diseases. And so we use it at onset to classify the patient, but we do not look at it further down the line. But this is something that instead other groups have done, and it could be clinically relevant. But again, it depends on how you are dosing your C3-NAF.
Okay, thank you. So I think we have 2 more minutes for questions, and I have a question from Dr. Ace Akbas. The question is for patients with immune complex MPGN with C3-NAP positive with persistently low C3 levels. Do you start treatment with prednisolone only, or you're immediately associated with MMF and low dose prednisolone?
So I would drive my decision based on the entity of the proteinuria and on the entity of the proliferation in the renal biopsy. If the patient has intense proliferation in the renal biopsy and, a very little sclerosis, so very active disease and a lot of proteinuria, I would definitely associate the mycophenolate mofetil as well.
Okay, so we have another question from London. It's Dr. Sergio Camilo Lopez Garcia. The question is, what is your opinion on the use of rituximab in IgG-mediated C3 glomerulopathy?
Yeah, so that's a really good question. Rituximab works very well if you have anti-complement factor H antibodies. If you do not, for treating patients that have positive C3 NAF, despite the fact that it makes a lot of sense and you would imagine that it would work because it would eliminate the antibodies, in reality, success has been limited, at least in the published cases. Probably the reason is that to be effective, you would have to completely eliminate these antibodies, whereas we know that with rituximab, since you don't eliminate plasma cells, you cannot achieve a complete elimination of the antibodies. So in reality, it is not probably the most effective therapeutic approach.
Okay, thank you, Marina. I have few more questions, but I fear that our time is over, and I would like to thank you for the excellent presentation and all of you who followed this webinar for your very active participation. I think there are a few people who asked questions, but I think it will be difficult to continue because we will be disconnected very soon. So I think when you really have very urgent questions, you can email them to Marina and discuss privately with you. Thank you so much.
I will be happy to respond to emails. Thank you.
Thank you all, and hear you soon on the webinar of ERKC3.